Here we are back together again, friends, for another episode of the Juicebox Podcast. Today's guest is Jordan Wagner, a nurse, a diabetes educator, and a person living with type 1 diabetes. And today we're going to talk about preparing yourself for being in the hospital with type 1 diabetes. The podcast contains so many different series and collections of information that it can be difficult to find them in your traditional podcast app sometimes. That's why they're also collected at juiceboxpodcast.com. Go up to the top, there's a menu right there, click on Series. Defining Diabetes, Bold Beginnings, the Pro Tip Series, Small Sips, Omnipod 5, Ask Scott and Jenny, Mental Wellness, Fat and Protein, Defining Thyroid, After Dark, Diabetes Variables, Grand Rounds, Cold Wind, Pregnancy, Type 2 Diabetes, GLP Meds, The Math Behind Diabetes, Diabetes Myths, and so much more. You have to go check it out. It's all there and waiting for you, and it's absolutely free. JuiceboxPodcast.com. Please don't forget that nothing you hear on the Juicebox Podcast should be considered advice, medical or otherwise. Always consult a physician before making any changes to your healthcare plan or becoming bold with insulin. This episode of the Juicebox Podcast is sponsored by the Omnipod 5. And at my link, omnipod.com/juicebox, you can get yourself a free, what'd I just say? A free Omnipod 5 starter kit. Free? Get out of here. Go click on that link, omnipod.com/juicebox. Check it out. Terms and conditions apply. Eligibility may vary. Full terms and conditions can be found at omnipod.com/juicebox. Links in the show notes. Links at juiceboxpodcast.com. Today's podcast is sponsored by US Med. usmed.com/juicebox. You can get your diabetes supplies from the same place that we do. And I'm talking about Dexcom, Libre, Omnipod, Tandem, and so much more. usmed.com/juicebox or call 888-721-1514.
I'm Jordan, and I'm 31 years old. I've had type 1 diabetes roughly 26 years now. Growing up with diabetes, I was very fascinated by it, learning about management and all that. That led me to diabetes camps. I went to Chris Dudley basketball camp in Vernonia, Oregon. That was a huge influence in my life of getting me really interested in living a healthy life with type 1 and that you can really thrive with it. Like Chris Dudley was my role model growing up. I played in the NBA for 16 years with type 1. And that led me to look at like the healthcare field. And I really did not know what I wanted to do with that. But when my uncle went into a coma from low blood sugar when I was a senior in high school, went to visit him, his nurse was a male nurse. And at that point, I didn't know that guys were nurses. Mm-hmm. And so I chatted with his nurse, and his nurse told me all about the nursing field and really encouraged me to look into that. And so that's what I did. I looked into it and ended up going to nursing school, became a nurse, and knew that I ultimately wanted to be a diabetes educator. And so after nursing school, I ended up going to a couple different hospitals, but worked on diabetic and kidney units just to get that experience there. And that gave me enough experience after about 5 years, or 4 or 5 years, to feel comfortable to sit for the board exams or the exams to be a diabetes educator. Mm-hmm. And so did that, passed the exams, and I've been a diabetes educator ever since.
That's awesome. Chris Dudley, by the way, on episode 515 of the podcast.
Okay, there you go.
Yeah, he was on talking about his camp. Is that camp still going? Do you know?
It actually is, yeah. So I don't know exactly where it's at now. They had to move the location, but it was in Vernonia, Oregon for the longest time. And it was just the greatest. Yeah. I mean, I worked there on staff for a little bit. I went there as a camper for 5 years. I mean, I have lifelong friendships from it, and it set me up very well to understand that I needed to take care of this if I wanted to thrive like Chris Dudley did.
Yeah, had a big impact on you.
Huge impact.
Yeah, excellent.
Yeah.
So you became an RN first?
Yeah.
Okay.
So RN. So I'm a BSN RN CDCES.
Wow.
Yeah.
Okay. EIEIO.
A lot of letters, I know.
And then how long have you been practicing as a diabetes educator?
About 5 years professionally. I always tell people it's really been like 26 plus years with my personal experience with type 1, but 5 years officially as a diabetes educator.
How do we find ourselves knowing each other?
Trying to think here. I think I joined the Facebook group a handful of years ago, and I just started seeing that it was making such a big impact in people's lives there, and I started sharing it with people at the hospital. And so I think that's how we got connected, was just through the Facebook group and posts over the years.
Well, Jordan, I'll tell you that I pay attention to what you put on social media, and I know you obviously through the Facebook group, but at the same time, when I see a person like yourself who is so dedicated and thoughtful about how they're helping people and sees this whole thing, in a way that I think is very clearly, when that person says that you think I'm doing a good job, I'm very touched by that. Like, sincerely, if I see you put something online that says like, you should try this podcast or take a look at this, I think I might really actually be doing something right here. It's the same feeling I have as when I met Jenny and the first time she said to me, I forget exactly how she put it, but she's like, Scott, you could do this professionally. And I thought, like, I was really touched by that.
Yeah.
And so it means a lot to me that this thing that we're putting out there, you're seeing it, you believe in it enough to tell somebody else about it. I really appreciate that.
Yeah. Well, and I truly do believe in this wholeheartedly. I mean, even implementing things from the podcast into my own management. And when I found the podcast, I was like, oh, I've had diabetes such a long time. I can handle this, so I don't really need to learn anything else. And that was such an arrogant way to go about it. But I get into the podcast and I'm like, man, this is incredible. And just implementing things I learned on the podcast. I mean, I'm getting my A1Cs and the high 5s, low 6s like for years now.
Awesome. And
it's really cool. It's just a really cool thing. So I believe in sharing that because there's not a lot of good education resources out there. And so this is something that it's a free resource. And it just benefits so many people. So it's something that people should know about.
I'm going to let you add to that resource. So and by let you, I mean, I'm going to send you a note, Jordan, and say, hey, would you like to make a series on the podcast? You tell me what you want to talk about and then come on and speak about it. So you sent a great list, and we're going to record a few times and put together a short series with you so that people can get, from your perspective, what might be important for them to pay attention to.
Yeah, absolutely.
Yeah.
So
where do you want to start?
Yeah, well, I think for this one right here, really want to talk about diabetes management in the hospital. That's just something that a lot of people might not have a lot of experience with outside of being diagnosed with diabetes. I know a lot of people being diagnosed with type 1 end up being in DKA when they're diagnosed. Mm-hmm. And that's a very traumatic experience potentially, but that also could be your only experience with going into the hospital. And so I think there's some things that I've seen as an inpatient educator that could be helpful for people to understand about going to the hospital, different situations, scenarios that may come up outside of that initial diagnosis. Okay. And so that's kind of what I really wanted to dive into here today.
I'm happy to. So we're talking about you've got type 1 now and you find yourself back in the hospital for some reason.
Exactly. Yeah, exactly.
How do you manage that scenario?
Right, exactly. Yeah. I mean, one of the biggest things I could start off by saying is that hospitals are unpredictable. Depending on what size hospital you're at, you come in and maybe you need an MRI or something like that. You could be waiting for days to get that MRI. And you might need to be NPO, so nothing by mouth, for the particular MRI. And so, how are you going to navigate that with your blood sugars going to something where you're not supposed to be eating or drinking? And then to find out at the end of the day, oh, a trauma came in and you've been bumped and you're going to have to do this again tomorrow. So there's a lot of situations like that come up, and the unpredictability can be really challenging.
What usually happens then? Do they just keep people's blood sugars higher?
Without a doubt, yeah. So one thing I like to tell people is that a hospital is not there to fine-tune the diabetes. It's there to stabilize it. And essentially, they care that you're in a safe spot. So from a doctor's perspective, if your sugar is 250 for multiple days at a time, you might not feel great at that, but they're looking at it and going, oh, well, this person's not going low. They're not going crazy, crazy high. So we're good with that. So they're going to intentionally run you a bit higher. Mm-hmm. And you need to be aware of that. So I think as a type 1, if you do have that tight control, you want tighter controlled blood sugars, you have to communicate that. you may receive some pushback. That's something you have to be ready for, which I think is helpful when you have someone there to advocate for you, someone who knows your diabetes well, who can be there to advocate. Because we don't know the situation of why you're in the hospital, right? I mean, this could be a planned surgical procedure. You need to be in the hospital. Or maybe you have like appendicitis. But, there's accidents, right? Well, you could be driving down the road, have a car accident. You have type 1 diabetes, and now you're in the hospital. As a type 1, you don't need to prep for every possible situation, but just have a general idea of going into potentially tough situation. Like, what are you going to do? Like, just maybe the thought exercise of like walking through this in your mind, like come up with a plan.
Because what happens, real world, what happens is that somebody says 250 is fine, but if it happens to be 300, then that's not so bad either. You're sitting there feeling terribly, or maybe you're, I always think of it in a slightly different way. Like maybe you're a person who's already got like an 8.5 or a 9 A1C, and then you go to a hospital and see that the hospital was perfectly fine with your blood sugar being 250. Then you go home thinking like, well, I don't know why I'm trying so hard. 250 is okay. Diabetes comes with a lot of things to remember. So it's nice when someone takes something off of your plate. US Med has done that for us. When it's time for Ardent supplies to be refreshed, we get an email. Rolls up and in your inbox says, "Hi Ardent, this is your friendly reorder email from US Med." You open up the email, it's a big button that says, "Click here to reorder," and you're done. Finally, somebody taking away a responsibility instead of adding one. US Med has done that for us. An email arrives, we click on a link, and the next thing you know, your products are at the front door. That simple. usmed.com/juicebox or call 888-721-1514. I never have to wonder if Ardent has enough supplies. I click on one link, I open up a box, I put the stuff in the drawer, and we're done. US Med carries everything from insulin pumps and diabetes testing supplies to the latest CGMs like the Libre 3 and the Dexcom G7. They accept Medicare nationwide, over 800 private insurers, and all you have to do to get started is call 888-721-1514 or go to my link, usmed.com/juicebox. Using that number or my link helps to support the production of the Juicebox Podcast. Today's episode is brought to you by Omnipod. Did you know that the majority of Omnipod 5 users pay less than $30 per month at the pharmacy? That's less than $1 a day for tube-free automated insulin delivery. And a third of Omnipod 5 users pay $0 per month. You heard that right, 0. That's less than your daily coffee for all of the benefits of tubeless, waterproof, automated insulin delivery. My daughter has been wearing an Omnipod every day since she was 4 years old, and she's about to be 21. My family relies on Omnipod, and I think you'll love it. And you can try it for free right now by requesting your free starter kit today at my link, omnipod.com/juicebox. Omnipod has been an advertiser for a decade, but even if they weren't, I would tell you proudly, my daughter wears an Omnipod. Omnipod.com/juicebox. Terms and conditions apply. Eligibility may vary. Why don't you get yourself that free starter kit? Full terms and conditions can be found at omnipod.com/juicebox.
Exactly. Yeah. It sets up a really poor example.
Yeah.
In my opinion. And, as an educator, I'm always advocating for tighter controlled glucose levels. I see it from the doctor's perspective too. Like,
yeah,
they are managing a lot of tough situations. And like, for example, my hospital is a trauma 1 hospital, huge 700 plus bed hospital. So a 250 blood sugar is pretty low priority for someone who might be having like a potentially fatal heart attack, right? So I get it from both sides, but I think the type 1 advocacy is going to be huge in making sure your blood sugars are well controlled in the hospital.
I mean, the reason it's happening, it's not unreasonable, but it's also not valuable as an answer to you, the person whose blood sugar is that high.
Absolutely. Yeah. Oh, absolutely.
Seriously, like if you're in a car accident and one medic shows up and one guy's worse than you are, I understand them going to him first. That's not helping you. And if you died later, the postmortem on that would be, well, I helped the person that was more direly in need. And everybody would go, well, that was the right thing to do.
Yeah.
There's a difference between what the system can manage, what other human beings at a hospital can, reasonably accomplish in a shift, and what you need, deserve, and require.
Absolutely.
Yeah. So you need to be the one who says, look, you got me a 250 here, but I'm not okay with this. And what would you say then? Like, what if you didn't, like, there's a difference between, like, if that happened to my daughter and I was there, I'd say, look, we just need to move this here and move this here. But what if you just don't know what that thing to do is? You don't want a 250, but you don't know what to say next.
Yep. So that's where I think the planning ahead comes into play here. So I'll give you an example here. I had surgery back in July. I didn't have to get admitted to the hospital, but it was a hospital-like scenario, the surgery center. I created a full page document outlining what I wanted to have done with my blood sugars, where I was comfortable at, my Dexcom information. So I gave my phone to the surgical tech, the RN there, and he had that and knew my phone password, so he could always access the Dexcom. And then I had my wife. I had her trained up on my pump, and I know a lot of other people in this group have done that too, where they've trained a spouse on how to use a pump. Mm-hmm. And I presented that outline to the providers there, so they had a clear understanding. So,
Jordan, did they listen to you because you're a professional, do you think?
It's possible.
Yeah, you're not going to know that.
Honestly, though, most people don't come in with a plan like that.
Whether I was a professional or not, if I had a plan like that, people would be like, "Ooh, this is fancy," and probably listen to it.
They would most likely. You at least have a much better shot of them actually listening to it.
Okay.
If you have something typed up like that. And so I suppose it could be a smart idea to have a little something typed up. Like, it doesn't have to be the nitty gritty, but like, hey, if an accident happens and I'm hospitalized, I prefer my blood sugars to be in this range. This person is my go-to if I'm not able to handle my pump or my diabetes things here. And then you just maybe carry that with you, right? Keep it in your little bag, and then you've got that there. So then it's not that you're just getting hospitalized and you go, oh crap, I don't know what I need to do. You're like, I've already had this typed up, and like, maybe we can change a little thing here and there, but I've got a plan. And then you can present that to the doctor.
Yeah, because if you're not pre-prepared, then it's not a thing you're going to be able to do in the moment.
Right. Exactly.
Yeah. Okay.
Yeah.
I guess you could even keep it on your phone too, like in a notes app or something like that.
Absolutely.
And make sure that like whoever your person is in that situation has access to it as well.
Yeah.
So what do you think needs to be on that document?
Sure. So I would say that if you're using insulin, you should have all of your settings there. So whether this is the pump or if you're on MDI, so multiple daily injections, have your long-acting dose there, your mealtime doses, your correction factors, and have that easily accessible. Because here's another scenario that can come up. You've got a patient going, I don't want to be this high. I don't feel good. And the doctor goes, okay, I hear you. We'll increase your insulin. It's not uncommon for doctors to make substantially large increases to insulin. Honestly, I think it's just maybe even a lack of understanding sometimes. Mm-hmm. I mean, if you say you have like a hospitalist doctor, they're a general doctor. They're very intelligent people, but they are managing so many different conditions that they might not have the expertise in insulin dosing. And so maybe you go, I need a little bit more Lantus. Well, a little bit more Lantus to them could be 10 to 15 units. Okay. And then all of a sudden you're flat on your face the next day.
So you actually talk a doctor into helping, then they do the wrong thing, then everybody gets scared, and now you're back to where you started, probably worse off.
You got it.
Yeah. Okay. Yep. All right.
Yep.
Okay.
So having your baseline settings, that's going to give them something to work with. Here's the other reality too. A lot of people report their settings and they're not actually accurate. What I mean by that is maybe I come in and say, oh yeah, I take 25 units Lantus, but I haven't actually been doing that for a long time. It's just what's prescribed. So the doctor sees that, right? And then they're going to automatically probably reduce your basal by about 20%. So you'll be at 80% of your home dose. And so if you actually are following your prescriptions and taking what you report, you could be running high to start because they're playing it safe and reducing your basal rates there.
Right. You know, it always shocks me when I say to somebody while I'm interviewing them, I'm like, well, what's your basal rate? And they go, I don't know. I have to look. I'm not that involved in Ardent settings anymore. And I know Ardent settings.
Yeah.
I'm not saying I'm special, but like, it's just your basal and like,
yeah,
just know it. You know what I mean? Like, because also for day to day, if you're not in the hospital, for day to day, remembering that, I don't know, you changed your basal from 1.1 to 0.85 and hey, I've been high for a couple of days now. Like maybe just having that number in your head would make you think, oh yeah, like I've made my basal different before. Maybe I should put that back now.
You got it. Yeah.
Yeah.
That's like the whole idea of the basal testing. Like you got to know your baseline before you're hospitalized, because you get hospitalized, everything is going to get thrown out the window, potentially. Who knows what's going on? Your body's going to be stressed out. It's already going to be running a little higher. Doctors might not be giving you enough insulin. So you have to understand your baseline.
Yeah.
And that's where taking the principles of this podcast and other episodes are going to be so important. So that time that you do get into that somewhat emergent situation or you're in the hospital, you have a solid baseline to look at and then work with.
I think it's important to say too, like nobody wants to think about like, oh, I'm going to end up in the hospital one day. But the truth is it might not be today. And it might not even be, I don't know when it's going to be. You're all going to end up in the hospital at some point.
Right.
Be ready for it. I mean, this whole diabetes thing is about, it's so funny that pre-bolusing is such a big part of it, because preparing is really the core of the whole thing. Like you just have to be ready and know what you're talking about, so that you're not, so that when the fight starts, you don't find yourself diving behind a rock because you don't know what else to do. Like you need to know what you're going to do when the hands start flying. Like that's kind of the way I think about it. So
absolutely. Yeah. And speaking of the pre-bolus there, so it's also not uncommon to be dosed with insulin after you've eaten your meal in the hospital. Depending on your nurse, there might not really be that sense of urgency. So I've seen patients, type 1s, eat a full meal. The nurse gets to them 30, 45 minutes later with their insulin.
Yeah.
And then, they're 350, 400 the next time. Right. And then if that's not done well, you might have the doctor going, wow, we do not have enough insulin here. And then bump up the insulin too much. And now you're low again.
All the time.
And you get stuck in this roller coaster mode here. So it's like advocacy, right? Being prepared. Those are some of the biggest things that could really hit home there. And then as far as the meals, you should probably have a conversation with the nurse and let them know, like, I am a reliable person. If you're not struggling with, nausea, vomiting, let them know that you can keep your food down and that you want your insulin 15 minutes ahead of time, even 5 minutes ahead of time, just before you eat the food. Because in the hospital, most nurses are going to err on the side of, well, let's make sure this patient can actually eat the food before I give the insulin.
Yeah, they're trying not to make more problems for themselves, functionally for themselves while they're working.
Absolutely, yeah. And like low blood sugar, for a lot of people, is seen as like the absolute worst possible thing in the hospital. Like I've seen it before where a patient goes low one time, they're like 65, they barely felt it, not a big deal, but the doctor says, we're going to hold you another day to make sure that your blood sugars are stable.
While we make it less stable.
Yeah.
Also, don't disregard the fact that food coming from the cafeteria at the hospital is garbage food.
Oh, it is bad.
Yeah, right. So there's going to be that impact as well. You said something a second ago that I wanted to expound on, and I've had a number of experiences around this.
Yeah.
When you start off a medical procedure, I find it is very worth spending 2 minutes establishing with the physician that you are a solid person who understands the situation.
Absolutely.
Not a cocky thing, not like, I've been doing this forever. You don't need to tell me. Like, just say, look, I understand that you meet all kinds of people, but I want you to know this. My daughter's A1C has been between 5'2" and I forget what 6'2", 6'4", whatever, for a dozen years. We know what we're doing. We know how to take care of these meals. I know how to keep her blood sugar stable. You tell me she can't eat overnight, I got no problem. I can bring her in with a stable blood sugar in the morning without her having eaten. We're here now. You want to put her under for 10 minutes. Don't worry. She's going to be okay. Like, you know what I mean? Like that kind of stuff, like, and give them a few examples of what you mean. What I've learned, I think, is that it doesn't take long for you to get across to them that not only do you know what you're talking about, but you might know better than they do, which I've actually seen it bring comfort to them.
It's true. It can bring comfort there. And I like what you said, that you're giving them some examples, because a lot of professionals, healthcare professionals, they work with, like, they want the data. Right. So if you're saying, oh, here's my A1Cs, you do see people come in and like not want to talk with me or one of the doctors because they say they know what they're doing. But then you look at their information, you go, respectfully,
Yeah.
your A1Cs are 8 to 11% for, I can see, at least 5 years here.
Well, I think what that could be sometimes is people saying, like, don't look at me because I don't want to have to explain to you that I'm not doing as well as I would like to be or that you would like me to be.
Right.
And it kind of brings me to my next point, which I think I've made on the podcast a number of times, but like I grew up with a lot of friends who were police officers.
Yes.
And these are guys that if you knew them personally, they're just lovely people.
Right.
But every day at work, everyone's lying to them all the time.
So true.
Yeah. And then except for the people who aren't, and then how do you figure out who's who?
Right.
And I wonder if I'm a physician and what I'm first of all, I'm working in a hospital. This is a place where people come in emergent situations, right?
Right.
And not just because you got hit by a car, but because something in your body broke down or doesn't work or something like that. The people they see with diabetes are not, generally speaking, the healthiest on top of it patients. So then they start thinking that's how everyone is, right? You start generalizing whether you want to or not.
Yep.
And then you come in with your 5-6 A1C and like, I've been listening to Juicebox Podcast for a dozen years. Like, watch me do this. That's not what they're going to think. And they commingle type 1 and type 2 together immediately.
Big time. Yep.
Right. So now you're just a person with diabetes. And most of the people I know with diabetes that come in this hospital don't know what they're doing. So you don't know what you're doing. So I'm not going to listen to you. And you get written off before anybody speaks a word.
It's so true.
Yeah.
And that's why I think having that conversation is important. Physicians can be very quick in and out of the room. And so letting them know, like, this is important to me. I need to discuss this with you. This is going to be very important. You have to do that early on in your hospitalization, because I've also seen it where patients have a low A1C and the physician's thought is, well, surely this is false. Let's see if they have some like hemoglobin disorder, or maybe they have some kind of liver disease going on.
The way I try to think about that, Jordan, is like, imagine how many people they've seen that they can't believe that you're taking good care of yourself.
So true.
Yeah. Their experience is so great that when you walk in there with your 6.5, even a 7 probably, right?
Yeah.
Like they're like, well, this had to happen by mistake. Like, you know what I mean? Like, and we see that with regular endocrinologist appointments. I see it constantly. People find this podcast, they get their stuff together, right? They go back 3 months later and they're like, go ahead, give me the needle, because they're dying for you to get that A1C back. It comes out, they're super proud of themselves. They've been working super hard for 3 months. They roll out their lower, more stable A1C, and the doctor goes, we got to cut your insulin back. You're getting low all the time.
Mm-hmm.
I've heard stories directly from dozens of people, probably more, who will say to the doctor, no, listen, here's what I figured out. Like, they'll show them graphs. Like, I'm not getting low. And the doctors can't bring themselves to believe it because they're so indoctrinated in what they've seen all these years. And,
so true.
Yeah.
And I mean, building on top of that, you just said the graphs there. If you have a CGM, continue to wear that CGM in the hospital, because that's cold, hard evidence, for lack of better words, that things are in control there. I mean, you could show them a clarity report of the last 90 days or whatever it is to show them that you're in control. But also that's going to help with even treatment decisions.
Yeah.
Because in the hospital setting, we're only using point of care testing, right? We're poking your finger. We're seeing where your blood sugar is at. If I can come into someone's room and see that they have a CGM on, and I'm like, oh, great, I can look at this graph and see and pinpoint where there's problem times.
Mm-hmm.
And maybe we need to adjust the food they're eating, or maybe we need to adjust their insulin. And that's something that you can report back to the doctor there. So whatever you do, keep that CGM on. Same goes for the insulin pump, truly. But I will also tell you that you're going to see some pushback from some of the doctors.
About wearing a pump or even a CGM?
It could be both, but it's going to be way more heavy on the pump side.
If somebody told me to take that CGM off of Arden, I'd be like, that is not happening. Like, you're not taking that off of her. Because also, I think your point is awesome. Now you're settled and you're in the hospital for a stay. They don't want to give you your insulin at the right time. And you can turn to them and go, look, here's what happened. This is what I told you was going to happen. Like, my blood sugar went up like this. If we would have just put the insulin right here, that wouldn't have happened. Like, can't we try that?
Yes.
Or can't I keep my pump on and we do this together? Like, I know you've got a bunch of people to help and it's probably hard. What I'm thinking is, even if I'm a nurse who wants to do this with you, now there's a cascading effect here. I'm going to give you your insulin 15 minutes before you eat, but I'm not in control when the food comes.
Correct.
Right. And now I'm going to I got 20 other people to help. And I got to worry that I gave you insulin and the food didn't show up and you're in that room by yourself with the door closed and all the other stuff that comes with it. What if they vomit? What if they do this? What if all the things that I've seen happen in the past happen? So you get into that what if situation. Honestly, Jordan, the way you're describing it and where the conversation is leading me, what it tells me is that if it's not a joint effort between the hospital and you, there's no way to actually accomplish this.
100%. It's got to be.
Yeah, it has to be that. Right. And by the way, there's a new nurse and a new doctor every so many hours. You're going to have this conversation over and over and over again. Just because you told the first person doesn't mean the next one's going to understand.
You have to. And then as hard as this is, stay patient. Because depending on which doctor you see, and for lack of better words, I'll say a neurodivergent doctor walks in who might be very impatient and not wanting to talk to you and has an agenda and only is going to speak to that agenda right there. Mm-hmm. If you're not patient and you have a little attitude because you've explained this 10 times now, that doctor might flat just walk out of the room.
Oh, yeah. Yeah. The 10th time you say it's got to be like the first time you said it.
Exactly. Yeah. So, and that's challenging because you might be in pain. You might be feeling terrible from a high blood sugar. And getting back to the earlier point of advocacy, that's where having that special person there for you who can speak to your needs, who can speak to the situations going on, maybe when you fully can't, is going to be so important. Mm-hmm. So you need to have that set up ahead of time.
We all have the practice of explaining to Dexcom why we need a sensor replaced and having to do it a second time. You just take that experience and use it in the hospital.
Exactly.
I should say, first of all, like Arden's experience with CGMs is very good. Like we don't get a ton of them replaced. But it is crazy, like, you know, if they happen and, you know, I don't know, in January, you got a call and they ask you their questions that this is the poor guy on the phone. This is the questions he's got to ask you. And then, you know, 3 months later, another one, a year later, 2 more, 5 years later, you're doing it again. And someone asks you where you're putting, you know, where do you put your sensor? Like, are you following the whatever? Like, there is that feeling inside of you. It feels like I've told you this 6 times over 5 years.
Right.
You haven't. That person doesn't work there for 6 months probably. And they're just reading to you from a list. So like that practice that you have to use in that situation of just saying, look, I've said this 1,000 times, but I haven't said it to this person even once.
Exactly.
Yeah, you have to keep that in mind. You have to find a way to advocate. But you know, I hate the word advocate for yourself because it makes me feel like someone's not doing their job.
I know.
But you have to advocate for yourself and you have to do it in a way that makes the other person want to help you.
Absolutely.
I know that shouldn't be the way it is, but human interaction, like you've got to play the game.
You have to. Yeah, you really do. Yeah, just go into it with respect. And what I would say also is it's also okay to disagree with the doctor. Mm-hmm. So you are in charge of your own health. And so let's say the doctor goes, all right, we're going to increase your insulin. You're going up 10 units of Lantus or 15. You can tell them like, no, that's going to kill me.
Yeah.
Or that's going to drop me really low. Like, can we meet in the middle and maybe do 7 or something like that? It's okay to do those things. Again, you are in charge and you can also refuse anything too, right? So I don't know, maybe again, with the insulin increase or a different medication, you have the right to refuse a medication. Just because it's prescribed does not mean you have to take it. It's within your rights to say, no, I don't want to take that right now.
Yeah.
And a lot of patients don't know that. They'll go in and say, well, the doctor said I need to do this and that's why I did it. If you are someone who's really in tune with your body and really knows your diabetes, chances are you know way more about diabetes than the doctor in the moment treating you.
Right.
So use that experience.
So Jordan, I'm going to ask you a question that's probably difficult to answer, right? Because of what you do professionally. But is it not the case that most adults with type 1 just sneak their gear into the hospital and manage themselves privately and quietly?
Yeah, we definitely see that. Mm-hmm. And so I'll tell you, our hospital policy is if we encounter that, we have to bring security up to confiscate the insulin or the whatever medication they're using. That's what I'll say is that's the policy there. But does it happen? Yes, I do. I have encountered that where people are doing that.
I mean, I've seen it with my friends. You know, when I was younger, a friend of mine ended up in the hospital, calls me up and says, listen, I need you to go to my house, get my syringes, get my insulin, get my whole kit and sneak it in here for me because they're not helping me.
Yeah.
And he's like, and I can't get it accomplished. And then you're like, okay. You know, so I brought him his stuff and he he hid it in a bag and kept it with him. And if his blood sugar got too high, he brought it back down again.
Yeah.
I mean, I see all the reasons why that's not a good idea. Like, don't get me wrong. And I'm not advocating for that. I'm advocating for you setting it up with a provider.
Right. Have that conversation. Right.
Get it straight. But
yeah,
I mean, there are going to be times where people are just, you're not going to get through to somebody, or maybe you're just not going to be a good communicator. Like, maybe you'll just be in the moment when you're like saying like, I know what I'm doing, just shut up. And somebody's like, oh, you're crazy. And then that's the end of the conversation.
Yeah.
It's tough. Also, you have to open up for the possibility, and this is hard, but for some people listening, you might not know what the hell you're talking about.
It's true.
That's a tough one. Go take, steel man, the doctor side of this now. Is it, I got somebody standing in front of me ranting and raving that they know what to do. I look back at their records. They got a 9A1C for the last 10 years. That's not exactly indicative of knowing what to do. And now they're telling me, don't listen to yourself, doctor, listen to me. And you believe in yourself because you think I'm doing great. Maybe that's what you think, So
right. And there's situations too that despite having flawless control at home, that just are going to throw you for a loop in the hospital. Like, for example, steroids come into play all the time, right? That's going to really, really throw your blood sugars up, especially if, like, let's say you're having an acute asthma attack, right? Or someone with COPD, they might hit you with some insanely high doses of steroids. And if you're not prepared, like your sugar could go to 600 or more, right? And so in those cases there, maybe you do need to have the expertise of maybe like an endocrinologist. So some hospitals are going to have endocrinologists in the hospital. That's not every hospital. Yeah. Some hospitals have diabetes educators. Maybe it's like, that's the time where you go, hey, can we request the endocrinology team or the diabetes educator team to come on board my case and help out with this? Another scenario we see a lot is tube feeds. That's not something most people encounter on a daily basis. Right? Maybe you're not able to eat by mouth for some reason and they have a tube down your nose into your stomach. That's a lot of carbohydrates that you might not be used to having. And that's going to really throw off your insulin needs.
And hitting you differently than it normally hits you. So, yeah, I mean, there are going to be times where it's not lost on me that if my kid went to the hospital and she ended up with like 150, 175 blood sugar for 3 days, but she wasn't low and she wasn't super high, I would say, you know what, it seems like everybody did a good job here.
Right.
Yeah. You know what I mean? Like, I think it's like you're talking about 250. I feel nauseous now because my blood sugar is this high. Nobody's doing anything about it. No, we're not doing simple things like, trying to time our meal insulin.
Right.
I think you fight the fight where the fight can be won and where it's safe for people. But I also would ask doctors to really remind themselves that high blood sugars are not a conducive scenario for healing.
It is not at all.
Right.
I mean, the infections go way higher. The wounds don't heal. We have to have tighter control. And that's where, I mean, I personally advocate for the patients a lot of that. We need this tighter control. And like Scott, like you said earlier, what is that teaching a patient who has an A1C of 8, 9, and now we're at 250 all the time? And the doctors are saying, oh, well, we're okay right now. You're not having lows. We're working on your blood sugars a little bit. That's going to teach that person that, oh, well, 250 is not that bad. And like you said, then it turns to 300. And
if we take the conversation around away from the individual and apply it to the greater good, I think that's the most important part of this conversation. So it's almost like the economy. Like, yes, this hurts, but if the whole thing gets better, you got hurt, but it's better going forward.
Right.
And I think that happens with diabetes. I think anybody who listened to the Grand Round series knows how I feel about it, but everything starts at minute 1 for every new person with diabetes, right?
Yes.
And so going into the hospital is a new minute 1 because it's an experience you've never had before. And if somebody is in that hospital who's already been told, hey, listen, we're shooting for a 7A1C, but yours is 8.5. You're doing great. I know you're trying. So now all of a sudden, ADA says 7, you're hitting 8.5. The doctor's trying to give you the benefit of the doubt or doesn't know how to help you. So now you've been told 8.5 is okay. Meanwhile, Jordan's running around with a high 5, low 6. And so is my kid and anybody else listening to this podcast probably, right? So you're at an 8.5 when you could be at a 6. But instead, a person of, that you're going to respect, a doctor, somebody who went to school, knows more than you in your mind, that kind of thing, has told you 8.5 is okay. We're shooting for 7, but 8.5 is okay. And then you go into the hospital and you realize, man, they got my blood sugar 50 points higher than I got it.
Right.
They must know what they're talking about. And if you're not all tied into all of this, you could easily rewire yourself into thinking that that's okay.
Without a doubt. Yeah.
And it's rewiring the doctors who were saying, hey, when she left here, she was fine. So I guess it was cool that her blood sugar was 275 while she was here because it's okay. It's such a slow, slippery slope of like, just keep accepting a little worse. Just keep accepting a little worse, a little worse, a little worse until you get to the point, honestly, like apply it to anything. 20 years ago, if I would have told you that an entire generation of human beings could be captured by moving their finger up and down to see pictures, you'd go, that's insane. That'll never happen.
Right.
Yeah, but we did it. We slowly got everybody there. You can slowly get better or slowly get worse.
Right.
And I just think that when you're presented with this is okay, your brain doesn't say, oh, this is okay, I'll shoot for better. It's this is okay, I'll try a little less. And as it slowly drifts away, I'll just keep moving the line that I'm okay with.
Absolutely. Yeah.
I think that's one of the biggest problems for people living with diabetes, not getting good information and good tools early enough on.
Oh, without a doubt. Yeah. And I would say from the hospital doctor's perspective, there's such a culture of, am I going to get sued over this? You end up having doctors wanting to play things safer, so avoiding those critical low blood sugars. And in the immediate setting, again, running 200, 250, 300, that patient is considered safer than if their blood sugar dropped way too low. Mm-hmm. I think there's just a lot of things floating around on the doctor's mind. I mean, some of my doctor friends, they're seeing 20, 30 patients a day.
Oh, yeah.
In the hospital. So they also don't have a ton of time to spend with everyone there.
Right. Not every one of your doctors is running around with 145 IQ and can keep 75 balls in the air all at one time. And remember to say to you at the end, hey, listen, we're going to keep your blood sugar a little high here, but let's remember that's not okay. And as soon as we get you out of here, we need to put it back here.
Yes.
It's for this moment. It's not forever. I take your point. Like, how am I going to even remember to say that in that scenario?
Right.
I'm only aware of it for having had all of these conversations, after the fact. I have the benefit of talking to somebody who also has the benefit of hindsight. And so they can say, when I look back over my life, this is how I slowly drifted to this place. I don't know how I'm supposed to explain that to an ER doctor and then tell them at the end of at the end, say, don't forget to tell them that, hey, listen, this is just for during treatment times, but we're going to put it back. And do you know how to do that? If you don't, let me explain to you about pre-bolusing and getting your setting. Like, they can't do that.
Right. No, they won't do that. I mean, they really won't.
They wouldn't or couldn't. It doesn't matter. Like, it's not going to happen.
It's not going to happen.
Right.
Yeah. Not in an inpatient setting. I mean, I've been in rooms with doctors before, and I assume it's just like I said, they've got other things going on. They're busy, and the patient's getting ready to discharge, and they go, all right, make sure you take your insulin for your food. Make sure you're counting your carbs. Try to keep your blood sugar, like under 180 or whatever. And all right, and then follow up with your endocrinologist in 2 to 3 weeks.
Yeah, they say the banal crap that doesn't lead anybody to success.
Right.
Yeah.
Right.
But they're covered.
Yep. But they covered their bases. Yep, for sure.
Yeah. Listen, I've been upset about this for 20 years. I've told this story before, but I was in an elevator once at a blogging conference, and I just said to this person who had an incredibly popular blog, why do you talk to them like that when you know that's not true? And that person just said, it's not my job. I'm not sticking my neck out for this. And I was like, oh, awesome. Great. I was like, I'm going to just go tell them how I take care of this.
Right.
That person said to me, you shouldn't do that. And I was like, I'm going to. I get it. Like, I do get it. And also, by the way, I wasn't being asked to write a blog or make a podcast while I was helping you in the ER.
Right.
It's a different situation. But that's why, maybe there are just some difficulties in life that are only able to be tackled in hindsight. Like, maybe there's just some stuff we can't actually get ahead of for reasons that are too complicated to fix or even understand, maybe.
I mean, it's a possibility. I mean, I think it's really important to learn from the past.
Yeah.
Right. So if you had a poor experience in the hospital, learn from that. Maybe write down your thoughts so you can reflect upon it. And then if it happens again in the future, you have a different idea of how to go into the situation there.
Well, Jordan, I want to make sure that you have out all your thoughts before I give you my big idea in case there's a doctor listening. But do you have everything out?
Yeah, I mean, I want to just say a few more things, a couple topics I wanted to hit real fast. But going back to the surgery stuff real fast, anesthesia is going to impact people differently. And what I mean by that is some people detox it really well and some people don't. Upwards of roughly 40% of the population have that MTHFR gene mutation, also known as the mother effer gene. And that is going to impact your ability to detox from anesthesia. So let's say that you have that gene mutation, you aren't able to detox the anesthesia, you could feel really awful for 3 to 5 days where you're throwing up after the surgery. So that's going to require some adjustments to your insulin dosing. If you're on a pump, temporary basal is going to be a really good thing to look at. You may need to reduce the amount of insulin that you're getting so that you're not having lows that then you can't treat because you're so nauseous. That's something to think about. Now, I never thought of this until I had the surgery myself, but they had to intubate me during my surgery because it was on my nose. When I woke up, my throat was so incredibly sore that I didn't want to eat food for a while. And so again, I had to look at my insulin dosing there, reduce it at sometimes so that I wasn't having those low blood sugars. So there's those kinds of factors there that maybe you don't think about until you've been through it.
Okay.
Like you said, the hindsight, learning from the past. So maybe you learn from that, you move forward and approach it differently next time.
Yeah. Yeah. I've been under a number of times, never have any trouble. And I just had a procedure where I was out for 45 minutes and I wasn't vomiting, but I felt like crap for about 4 or 5 days afterwards.
Yep.
And I think that anesthesiologist used a different cocktail than what I'm normally getting. And it really wrecked me for a while. I felt crappy for days.
Yeah. And steroids are really common to use in that process. I had requested that no steroids be used during my procedure. That was helpful. But it's very common if you get a large dose of steroids in conjunction with the anesthesia. So then you come up, it's a weird combination. So again, to tie this all back together, having that person there to advocate for you throughout your hospital stay is like going to be one of the greatest things possible.
Yeah. Yeah. 100%. Yeah. It's tough to have all the information you need and make sure there's somebody there with you. But again, I just think just be as pre-prepared as possible.
That's it.
Yeah, Jordan's initial idea of having this all written down ahead of time is just, it couldn't be a better idea. And put it on your calendar like every year. Like, hey, sit back down and make sure my emergency sheet is updated.
Absolutely.
Take 10 minutes to change your settings in it or something like that. Yeah.
Yeah. That's a good way to do it, man. Put it in your calendar there and make sure it's like on a yearly basis. We have a go bag. Like if there was a major emergency I needed to go, and we just updated ours not that long ago, updated all the diabetes supplies. It's a similar concept, right? It's being prepared for a situation before it happens.
It's stuff that's not fun to do that one day you'll be super happy you did it.
Absolutely.
Yeah, 100%. Anything else
we covered everything there. Okay. I'm sure I'll get off this and be like, I forgot that. But
that's okay. You're going to come back. We're going to tell people what we're going to talk about next time.
Yeah. So there's a couple other things I'd like to talk about. One of the big things would be like how like nutrition and stress impact blood sugars there. Definitely want to look at how ultra processed foods are really hurting the health of people in this country and in the United States. Eating a healthier diet without diving too much into it can actually really help with your insulin sensitivity and things like that.
Yeah. Okay.
We'll look at different CGMs and how that can compare to blood sugar checks and why there's some inaccuracies at times. There's quite a few things that can throw CGMs off. So that would be something to look at for sure. So we'll dive into a few different things there.
Yep. Just know that if you enjoyed listening to Jordan, I just said to him, you tell me if I gave you a series to talk to people about diabetes, what would you want to tell them? And he put a list together and those are the things we're talking about. So
yep,
that's what you're going to hear in other episodes. Now, Jordan, if you have a minute to hear my big idea,
let's do it.
Okay. So I don't want to give away too much about how I do things, but I guess I'm going to have to say this. So I was telling Jordan before we started recording that I keep a list of all of the repetitious questions that are asked by people in the Facebook group. And then we pre-create content for you so that we can answer those questions with that content. So instead of waiting to the moment when you say like, I don't understand this, and then somebody having to sit down and like dump their thoughts out to give it back to you, which is good. We still see that happen through the community. People give their lived experiences. But somebody from the podcast, or me, or somebody who's helping with the Facebook group will also come and say, you should try this episode. It has that information in it. Or here's a blog post that explains that. That comes not by mistake. That's a life lived helping people with type 1 diabetes and keeping track of that information in a repository somewhere so that it is accessible.
That's awesome.
And what I found myself thinking was, so again, this is going to be a bigger idea, but as the world gets more automated, we're going to lose more and more of those people who have been doing things forever, who just know how to do it and how it works best and what needs to be addressed and what's kind of bullshit. It sounds nice, but doesn't really help anybody. Like, they're going to have those ideas. And I am just a large proponent of people sitting down and talking into a microphone and then taking that audio and making it into a transcript and then feeding a large language model with that transcript.
Oh, that'd be crazy.
And I'm telling you that if I was a hospital, I would hire 3 dorks. I would stick them in a corner. And one of those dorks would be in charge of you coming in and just telling your story as the RN, telling your story as the nurse, telling your story as the doctor, the things that you think are important over and over again, and feed that large language model with everybody's lived experience.
Wow.
And then one day you'd have a prompt in front of you 25 years from now when people are still nurses, except that we've lost all the people who had the job for 40 years and knew what to do in the right situation, and everybody learned from them. And you could sit down at a prompt and say, this is what's happening right now. Here's this patient. Like, what do you think I should do? And instead of it, and it's not the internet that's being asked. It's every person who's ever worked at that hospital and shared their experience to give you a list of ideas of what to look into.
Yeah, I mean, that's incredible. That would be really incredible.
I am telling you, I think it's a huge, I'm literally trying to talk my son into starting a business where he just goes to other business and captures thought leaders' ideas. I think it's, I genuinely think instead of like waiting for the internet to give you the answer or waiting for just a generalized large language model to go out on the internet and pull back in the answer, like, why not get people who you trust to tell you what their experience was? And then one day you'll just have this, the hospital will have a pool of information. And then you could, if you want, put a group of doctors in charge of it to go look at it and say, you know what, that part, let's take that out. Somebody to review it and I'm telling you, man, it's a great idea. No one's going to listen to me.
That is a great idea. That would help a lot, honestly.
It would work for anything, but it would work so much better in healthcare because like if you went to a bicycle shop, it would work, but it wouldn't be that valuable. But in healthcare, where you have these doctors who just know this stuff because they've done it so many times, right? Or you have a nurse who just has this information that was not taught to them in nursing school, that isn't a thing that's written down anywhere, that they just know works. Like right. That's the stuff that you need to keep and I think amplify. I'm behind the scenes doing it for all of you guys. Like my last gesture, I want my last gesture to be that when I'm done with all this, juiceboxpodcast.com is just a prompt where you can ask questions and you'll be asking it of everybody who's ever had a conversation on the podcast.
I mean, that's such an incredible idea.
Yeah. And it'll work. So
yeah, I think it would.
Yeah. No, 100%. It absolutely will. Anyway.
It's a matter of just creating it.
Yes. I know this isn't a patent, but don't steal my idea. There you go.
All right. I won't.
All right, Jordan, hold on one second. This episode of the Juicebox Podcast is sponsored by the Omnipod 5. And at my link, omnipod.com/juicebox, you can get yourself a free, what'd I just say? A free Omnipod 5 starter kit. Free? Get out of here. Go click on that link, omnipod.com/juicebox. Check it out. Terms and conditions apply. Eligibility may vary. Full terms and conditions can be found at omnipod.com/juicebox. Links in the show notes, links at juiceboxpodcast.com. The conversation you just enjoyed was brought to you by US Med. usmed.com/juicebox or call it 721-1514. Get started today and get your supplies from US Med. Thanks so much to Jordan for spending his time with us. If you're enjoying Jordan on the podcast and you'd like him to come back, go find him on Instagram, The Diabetic Merce, and let him know how much you enjoyed him on the show. Hey, thanks for listening all the way to the end. I really appreciate your loyalty and listenership. Thank you so much for listening. I'll be back very soon with another episode of the Juicebox Podcast. If you're looking for community around type 1 diabetes, check out the Juicebox Podcast private Facebook group, Juicebox Podcast, Type 1 Diabetes. But everybody is welcome. Type 1, Type 2, gestational, loved ones, it doesn't matter to me. If you're impacted by diabetes and you're looking for support, comfort, or community, check out Juicebox Podcast, Type 1 Diabetes on Facebook. The episode you just heard was professionally edited by Wrong Way Recording, wrongwayrecording.com.